Hello, I'm Dr. Daniel Kelly, director and one of the four founders of Pacific Neuroscience Institute. And today I'm going to talk to you about the surgical management of patients with craniopharyngiomas using the endoscopic endonasal route or the supraorbital eyebrow route. Although craniopharyngiomas are relatively uncommon, here at Pacific Neuroscience Institute, we have a large experience and track record with these complex tumors. By way of background, it's important to realize that these are benign tumors. These are not cancers, and they tend to arise along the pituitary stalk and the gland. They cause hormonal loss, loss of vision, headaches, and in younger patients can cause growth failure. They only make up about 2 to 4% of all primary brain tumors, and they tend to occur in two major age groups in younger patients and in an older adult subset. They comprise about 10 to 15% of all pituitary region tumors, but over half of pituitary region tumors in children. There are two subtypes, the so-called adamantinomatous, which are more common, tend to occur in younger patients. They're often calcified and more invasive. And then the papillary subtype, which are less common, tend to occur in older patients and are rarely calcified and less invasive. But importantly, 80 to 90% have a BRAF mutation, which is something we can use to our advantage in treating patients with the papillary subtype. From a surgical standpoint, craniopharyngiomas are quite challenging given their location in the skull base. They become adherent to the optic nerves, optic chiasm, the pituitary gland, and stalk itself. And so, although surgical removal is the primary treatment, in only about 50 to 60% of all cases can we really achieve 100% tumor removal. And so, in many instances, other treatments, particularly stereotactic radiation, are needed to control future tumor growth. And in some cases, we can now use these targeted therapies with BRAF inhibitors for the papillary subset, although this is still somewhat an experimental therapy. Because of the intimate relationship with the pituitary gland and the pituitary stalk, hormonal therapy is really critical for many patients, and so close collaboration with our endocrinologist is essential in the optimal management of patients with craniopharyngiomas, and it really requires an overall multidisciplinary approach. And so our overall strategy for patients with craniopharyngiomas is maximal safe removal with preservation of pituitary gland function if possible, restoration of vision, and avoiding hypothalamic or other types of brain injury. And so certainly for craniopharyngioma, this is a team sport. And this is an article we published back in 2012, emphasizing the concept of pituitary centers of excellence and this multidisciplinary approach to these complex tumors. We have a long track record in our publications related to craniopharyngiomas, and this is just a sampling of some of the many publications that touch on management of craniopharyngiomas. So the traditional skull-base approaches have been used for many years, but in our experience, these have gradually gone away to a more keyhole concept. And today, for the vast majority of craniopharyngiomas, we use the endoscopic endonasal route or the supraorbital route, both shown here with the aid of endoscopy. And in fact, in about 80% of all of our craniopharyngioma patients, we use the endonasal route. And this is simply because of the location, which I'll get into. And we use the supraorbital eyebrow approach for only a minority of patients, typically for those patients who've had tumors that recur or grow cysts that are lateral to the chiasm, and in some children because of the small nostril size. And using the endoscopic endonasal route, it allows us to work under and behind the optic chiasm and optic nerve and over the pituitary gland. And so this is really an excellent approach because it allows us to work along the long axis of the tumor, which tend to be above and behind the pituitary gland. And so I'll just show you some examples here, but it's important to see that in our experience, and this is really over 20 years of my experience with about 80 craniopharyngiomas, you can see that almost half are reoperations because these tumors do tend to come back, and that in about 80% we have used an endonasal approach, and in only 20% the eyebrow approach. And so when we consider surgery and the approach, the key things we think about are the patient's hormonal status, what is the location of the optic nerves and chiasm, prior treatments, whether or not they might have hydrocephalus, and then we typically will pick one of these two approaches. And so here's just some examples. The important thing to note is that the great majority of craniopharyngiomas occur in this retrochiasmal space, and that just simply means behind the optic chiasm. So these arrows demonstrate where the chiasm is located, and you can see if we come in through an endonasal, through the nostrils, we can get to this tumor working above the gland and under the chiasm. And this works very effectively for the majority of patients. But for some, we can go either way, and we may choose a supraorbital approach in some. So what are the key factors to success in endoscopic endonasal surgery for craniopharyngiomas? Well, certainly patient selection and choosing the correct approach is essential. Having the appropriate experience for the surgical team and the instrumentation. For the nasal phase, because we make a very large opening into the intracranial space, we will harvest what's called a nasal septal flap, which is a vascularized flap, which we use to place into the skull base defect and prevent a postoperative spinal fluid leak and meningitis. And I'll show an example of that. The sphenoidotomy phase is opening the bone to get into the sphenoid sinus and to approach the sella. Then when we expose the sella, we want to make sure we get a wide enough exposure out to the edges of the carotid arteries, but not too wide so that we might injure them. And for this, we use the Doppler probe, which is very effective to listen for the carotid arteries. The tumor removal and gland preservation then takes place. And these tumors, again, the challenge is that they become very sticky. And you can see here in this photograph, stuck to tiny blood vessels, stuck to the pituitary stalk, to the optic chiasm. And so these are things that make these tumors much more challenging than some of the other tumors in this area, such as pituitary adenomas. And then after we remove the tumor, the closure of the skull base defect is essential. And for this, we use a variety of materials, including fat and collagen and bone. And hopefully you have a successful operation at the end with a complete or near complete removal and preservation of the critical structures. Just to emphasize the closure in a patient with a craniopharyngioma, and this is a drawing from an article we published a couple years ago on cerebral spinal fluid leak closure. And these are what we call grade 3 leaks because we make a large opening into the intracranial space. And when we remove the tumor, we have to create this multi-layered closure that includes a nasal septal flap. And patients will have a nasal packing in for at least 5 days after the surgery. So here's the setup we use in the operating room. This is the surgical team with our surgical monitors, with my ENT colleague, Dr. Griffiths. And you can see that we have 2 high definition flat panel monitors. Our hands are working around the nose. So it's truly team surgery, and using the natural corridors of the nostrils for our instruments and the endoscope. The surgical time for a patient with a craniopharyngioma can be anywhere from 4 to 6 hours, sometimes even a little bit longer for very large complex tumors. The blood loss is anywhere from 200 to 500 cc's, but it's very rare that a transfusion is needed. All of the patients will get at least 1 or 2 nasal packs to help prevent and ensure that we don't have a postoperative spinal fluid leak. An MRI is performed on postoperative day 1, and most patients will go home on day 2 or occasionally day 3, and some patients these days go home on postoperative day 1. We follow up with blood work around day 5, looking at cortisol levels and sodium levels, and some of these patients will have come in with low cortisol, and of course we don't check that if they're already on cortisol supplements such as hydrocortisone. They will see us in follow-up, both the neurosurgeon and ENT at around 7 to 10 days, and then an endocrine clinic follow-up. In terms of activity, patients are generally up and walking on day 1, but no strenuous activity for the first week. They can fly after 7 to 10 days, and driving is typically okay after 2 weeks. And generally anything goes, including exercise, after 3 weeks. So I'm going to show you a couple cases here. This is a gentleman, a 57-year-old man with 4 months of progressive left eye vision loss. And on formal visual testing, he had what's called a bitemporal visual field defect, meaning he was losing his vision on both sides. His visual acuity was 20/30 in the right eye and 20/800 in the left eye, very poor vision in the left eye, but he had normal pituitary gland function. And you can see here he's got this cystic and solid tumor, which is very typical. And he has this cyst lifting up and compressing the left half of the optic chiasm and the left optic nerve. And these are just some other views. And it does appear that the pituitary stalk wraps around and goes over to the right. So the goal here would be to preserve his pituitary gland function and to restore his vision. And so here is the surgical video. And you can see we're using a 30-degree endoscope. Now we're opening the dura here. This is in the skull base, working right along here. And we are now opening the dura above the pituitary gland. And the first thing we see are little vessels here that we have to preserve. And we see the cyst of the tumor sitting on top of the pituitary gland. And we're going to drain that cyst sharply with the scissors going to the cyst to give us some decompression of this space. And now we're going to start to remove the tumor. And what we see here is the pituitary stalk coming up and going from the pituitary gland up toward the right side. And we have to be very careful to preserve this blood vessel, which comes off the carotid artery on the left side and is going over to the pituitary stalk and optic chiasm. So we're separating this tumor from the top of the pituitary gland, from the optic chiasm, and from the pituitary stalk. And you can see with our endoscopic approach here, Dr. Griffiths is driving the endoscope and providing me a beautiful view, and we're able to remove this tumor in piecemeal fashion. But there are some small areas that we're going to leave behind simply because if we try to remove all of these little flecks of tumor, we'll end up damaging the optic chiasm and potentially the patient's vision. So then we very carefully fill the defect with a fat graft, as shown here. We lay some collagen over the defect. And then we're going to put some bone there to, again, help seal up this small defect in the skull base. And then this is the nasal septal flap that Dr. Griffiths has harvested. It has a blood supply to it, and it sticks to the skull base and will prevent a postoperative spinal fluid leak. It's reinforced with some additional fat and some more collagen, and then tissue glue, and then the nasal packing goes in. And so here you can see the patient's postoperative MRI on day 1 showing the nasal pack. These are fat grafts here. This is the pituitary gland looking good, and this is the enhancing nasal septal flap. And his vision improved dramatically. This is his 2-month MRI showing the pituitary gland function looking good, no evidence of tumor, complete resolution of his vision problem, and his pituitary gland function remained normal. Here he is at 1 year, and again, no evidence of tumor regrowth. However, another year passes and we see a little beginning of tumor growth here. And because of that, we treated him with stereotactic radiotherapy. And this was very effective, was completed in April 2019. And more than a year later, no evidence of tumor growth, tumor shrinkage, and he continues to do well with normal vision and normal pituitary gland function. So here's a case where we had a near complete removal, a very tiny residual, over time grew, but responded very well to radiotherapy. Now, here's another example, a 56-year-old man with poor vision over 5 months. Again, bitemporal vision loss, meaning loss of his peripheral vision, and poor visual acuity. Here we're opening the area in front of the pituitary gland and out over the pituitary gland, listening for the carotid arteries with our Doppler probe, and then working to remove this tumor. And this one extends up very high and back behind the optic chiasm. But you can see here again, doing the same approach, when we open the dura, we don't really even see the tumor. We see the chiasm and we see the pituitary stalk here. And so this looks like a very formidable task, but we reach up under the chiasm and preserve these tiny vessels that are important for the chiasm. And then we start to separate the tumor from the surrounding brain structures. And again, this is done with this very beautiful and highly detailed view that we get with the endoscopic approach. And we start to remove this soft tumor that separates eventually very nicely from the surrounding brain. Here we're using a device to cut the tumor up and suction it in. And again, progressively working in and around the pituitary stalk. We're making an attempt to preserve the pituitary stalk, even though he already has some decreased thyroid and decreased testosterone. And you can see this large tumor mass is slowly giving up in a sense, and that we're slowly able to remove it in several large pieces here. And then we're going to take a look with the 30-degree endoscope up into this space to make sure that we've really gotten a complete tumor removal. So now we're looking way up back behind the pituitary stalk and optic chiasm. And you can see this beautiful view we get with the endoscope up to what's called the third ventricle. And it looks really like we have a complete tumor removal at this point. So again, we do the same reconstruction with a fat graft carefully placed into this space, the collagen material, bone from the septum, which is gently wedged into the defect there, and then this nasal septal flap to help cover the skull base and ensure that we don't have a postoperative spinal fluid leak. So here we see the tumor before surgery. This is the postoperative CAT scan that we get. You can see the reconstruction here, some fat, so a little bit of air inside the head, which is very common. Here's the postoperative day 1 MRI showing a complete tumor removal with the nasal septal flap enhancing nicely, pituitary gland there. And more than 25 months out now, he's had no recurrence. He's not required radiation. His vision has normalized. He's doing very well, but he is on hormone replacement therapy. And this is one of the challenges. It is very hard to preserve gland function, and in some instances, we make it worse. So he's on hydrocortisone, thyroxine, testosterone, and once daily a DDAVP or vasopressin. And so again, close collaboration with our endocrine colleagues in managing these patients. The use of the supraorbital approach is only in about 20% of our craniopharyngioma patients, and this is a publication that came out in 2020 showing our use in a large cohort of patients, including some with craniopharyngiomas. And so we do use this for some patients with craniopharyngiomas, such as this child here with a very large cystic and solid craniopharyngioma through an IBI route. He was only 6 years old at the time, and so this is very effective, and particularly given that the nostrils are so small, it can be a very effective approach for children. Here's an adult, a woman, 46 years old with vision loss, and this was approached through a supraorbital route. In this particular case, the tumor was very calcified and very stuck to the optic chiasm and nerves, and so we did a subtotal removal so that we would not damage her vision. Her vision did get significantly better, and this is her scan 3 months after surgery. We did subsequent radiation treatment, and you can see now more than 5 years out, no evidence of tumor growth, and she's doing extremely well with normal pituitary gland function and normal vision. And I just showed this case, another large retrochiasmal craniopharyngioma in a 43-year-old man presenting with really complete pituitary gland failure. We were able to get a complete removal, but in this case, it is a papillary craniopharyngioma with the BRAF mutation. And so if eventually this patient were to have a recurrence, we would probably be able to use a BRAF inhibitor as opposed to radiation to treat this patient. And again, this is an evolving field, and we hope we'll have more targeted therapies such as this for our patients with craniopharyngiomas. And this is just a paper that came out a few years ago on the BRAF mutation. So this is something that we look at in our papillary craniopharyngiomas. So in conclusion, the endoscopic endonasal route is really ideal for the majority of our patients with craniopharyngiomas, about 80%. We do use the supraorbital route for some patients, particularly those with reoperations who have had prior radiation or in this location above the chiasm, or who only have a cyst growing, and in some children as well. We need to determine preoperatively if it's reasonable to try to preserve the pituitary gland and stalk. And a near or subtotal removal is okay in some patients to prevent significant complications such as vision loss or stroke. And we generally do not give radiation treatment, SRT, until we see tumor progression, because many of these very small residuals may not grow for many years. So we like to wait on the radiation until needed. But very important, again, to stress, the team approach is essential with endocrinology, ENT, neuro-ophthalmology, our radiation oncologists, and our neuro-oncologists. And hopefully we have more targeted therapies on the horizon. If you have a craniopharyngioma newly diagnosed, if you'd like a second opinion, or you have a recurrent or residual tumor, we'd be more than happy to see you here at Pacific Neuroscience Institute. Thank you for your attention.